Welcome to Analyzing Healthcare by Scale Community, which is an education-focused organization comprising of passionate global healthcare leaders. Analyzing Healthcare is Scale's podcast series dedicated exclusively to unpacking the myths and foibles that have been directed at US and global healthcare for as long as we can all remember. Is US healthcare broken? The worst in the world? Perhaps, perhaps not. Let's find out together as we invite thought leaders of healthcare to share their views. I'm your host, Roy Bejarano. Okay, so we're off and running and looking forward to the first of our, hopefully, many podcast discussions focused on the larger picture of healthcare in America and all the questions and all the machinations that come with that very large, hairy and complicated and probably scary topic. But we're persevering and we're pushing forward to try to unpack this question. Healthcare in America, what is it? And what's the right way to think about it? Typically, the next thought that comes is, how do we fix it? But I'm not rushing into that conclusion the way that we think, Webb and I think many people do. We're going to actually apply some analytics and objective assessment and comparison before we run into the judgment of healthcare in America. So, Webb, starting with you, what's your background in healthcare? Well, what's your journey consist of?
Yeah, well, look, it's a pleasure to be here with you, Roy, and it'll be fun to unpack healthcare. It's a complicated beast, as you implied, and there's lots to unpack, but it needs to be unpacked. Because it can be improved, and we should keep trying. But anyway, I've over the past 35 years run 5 healthcare companies. Over the past 20 years, really focused in the retail medicine space. So I started a company 20 years ago called Ready Clinic, which was one of the first companies to put healthcare clinics inside retail outlets. Various times we were inside Walmart stores, Walgreens, Duane Reade stores in New York City, HEB stores in Texas, and finally sold it to Rite Aid in 2014. So that was a 10-year adventure, and I continued to run it at Rite Aid for 3 years, and also ran a population health management company that acquired called Health Dialogue, and that was when Rite Aid was a $30 billion company with more than 5,000 stores, and that's also another story. But then Rite Aid and Walgreens got snarled up trying to merge together, and that was a deal that was ultimately or effectively blocked by the FTC. So in 2017, I moved to FastMed Urgent Care, so freestanding urgent care clinics, and built it to about 170 units, and we sold it earlier this year. So really for the past 20 years, really focused on trying to make, routine healthcare more accessible and affordable to people. And then since then, I wrote a book, called Here Be Dragons, which was published by Forbes earlier this year. And I've spun off a newsletter that's now on its, I think, 19th issue, really just examining different aspects of healthcare and sort of the pros and cons and challenges and opportunities in each.
So tell me about Here Be Dragons.
Well, it's really a story, for the most part, about my efforts to make routine healthcare, more accessible and affordable. And when we first came up with the idea of putting small healthcare clinics inside retail outlets, there were a lot of external obstacles to success, and we had to convince retailers to give us space in their stores, which they had never done this kind of thing before. We had to convince third-party payers to contract with us, and they were concerned about, could their members get quality health care, inside a grocery store or a big box store. There are a lot of regulatory obstacles. We wanted to use nurse practitioners and physician assistants in many cases, and that was problematic depending on various states. We had to convince consumers that they could get high-quality health care in a retail outlet. But slowly but surely, and I do mean slowly, basically we ultimately succeeded, and it was because really patients like the experience. They like the convenience and relatively low cost, and it was working. So I feel like we made a dent. We plowed some new ground. It was very challenging at the beginning. We also got a lot of pushback from the so-called medical establishment on the national level. AMA, the local medical societies. I think we're a little frightened of us, frankly.
What was the primary reason for that fear?
Well, we were open 7 days a week, extended weekday hours. And because we had a limited scope of practice, our patients could get in and out, predictably very quickly. And basically, they would walk in. This was initially walk-in business. And if there was a line, they would know how long it was going to be, because we didn't really treat anything that took more than 15 or 20 minutes. And they could go out and shop the store, and we'd take their, cell phone number, and we'd call them when their turn was up. And we were co-located with a pharmacy, so they didn't have to go make another trip to get a prescription filled. So the model worked very well, not only for patients, but if you think about the retail outlets that we were in, like Walmart supercenters that have hundreds of employees in those supercenters, it was a great solution for them too. So it was a good model, and it really did help. I think we made a contribution, but we were never intended to be something that was sort of standalone. We always wanted to be part of the healthcare ecosystem. And so we also were early pioneers in joint venturing with health systems. So I think between Ready Clinic and FastMed, I've probably done a dozen joint ventures with major health systems. And, there were benefits there in both directions. So it's been a wild ride in many respects. But again, I feel like we made a dent in the system by approaching it from the patient's point of view.
You've kept track of large big box retailers and their efforts to try to expand their footprint within healthcare. Some large provider organization acquisitions like VillageMD, like Summit Healthcare. What are your thoughts on their efforts to date? Are they going to continue to invest in the space? Is it a strategy that will ultimately pan out, or are they misguided?
I think it will ultimately pan out. There were some extenuating circumstances, and in some of the recent efforts to expand retail medicine. I think COVID, was a challenge. I mean, those retailers that expanded either during or just before, immediately after COVID, had some pretty challenging issues, mainly around staffing. So there is a tremendous staffing shortage in healthcare, as you're well aware, and that's driven wages up. And so when you're in a low margin business, where you're not able to pass your incremental costs on, to your patients, it's easy to get squeezed. And I think, as an example, VillageMD, basically built hundreds of clinics into that environment, and that made it very difficult. They sustained very substantial losses, as is public knowledge. But it's not over. I mean, I think that the convenience of healthcare delivered in a retail outlet, whether it's inside a retail outlet or in a freestanding urgent care, that's a pretty compelling value proposition for consumers. There are now, I think, 14,000 urgent care clinics in the United States. And I believe last year they served more than 200 million patient visits. So, it's not going away. But again, it's part of the ecosystem. And it really needs to be an ecosystem. I mean, most of those urgent cares and retail-based clinics have a limited scope of practice. So we can't treat anybody. We're not trying to treat every condition. We need to have places we can refer patients who need higher levels of care than we can provide. And so it's very logical for us to be part of the local ecosystem. And that's what's happening and what has happened. That's one of the reasons that we, partnered with large health systems, way back starting in 2005.
You've written a lot about the industry at large certainly in the last couple of years, working with Forbes. You've published a lot. Where has your interest focused? What are the topics that you have predominantly written about? What captures your peak interest and your attention?
Well, there are many aspects, as you know, as long as I've been in healthcare, there are actually many aspects of healthcare that I didn't completely understand. Not that I, claim to now. I mean, the system is very complex. Healthcare is very complex. So I've tried to focus on things that were topics that are important, and newsworthy at the same time, and tried to address them with some level of depth. So my articles, if people complain about my articles, they tend to say that they're too long. And, so I just decided, kind of to ignore that, frankly, because I just don't want to deal with these issues in a superficial way, because they deserve deeper attention. And so, I've ranged, all over the place, basically, from the need for more primary care to whether single payer system is better, to rising drug costs and what we do about that. My most recent article, just published actually yesterday on Forbes.com, is about about RFK and whether he will succeed in challenging the food companies, whether they need to be challenged, why they need to be challenged, and will it work this time? Because I think that one of the problems that our system has is that we have actually a very sick population today. 75% of our citizens are overweight or obese. More than 60% have at least one chronic condition. More than 100 million of us have diabetes. Another 100 million of us have heart disease. When you have a population that has that health profile and it's aging, it's going to be very difficult for any health system, whether it's single payer or, our model, to take care of everybody in the way that they may feel they deserve to be taken care of. And so at some point, we've got to move from a healthcare system, from a sick care system to a real healthcare system. And that's a huge transition, but a very important one.
Yeah, there's a lot of thought attached to those sentences. There's a lot of underlying analysis and assumption, and I think what I want to try to do is unpack everything involved in our understanding of healthcare. So, examples being 75% is overweight. I'm not sure that it's 75. Different sources give different numbers, but consistently they represent that we're more overweight than other countries. And I'll give you an example of a chart that I can share with you now. This is on our website. Obesity levels versus other G7 countries. We're worst in class. Whether it's 40 or 75%, it speaks to us having more unhealthy, prone to disease citizens than other countries do, which is a handicap if you're a health system. Same thing for physical inactivity. We're worst in class, not best in class. And then an outcome of that, diabetes, which is one of the most expensive chronic conditions, if not the most, out there. Especially until recently, we just solved for the rapidly rising cost of insulin. But until the Inflation Reduction Act, all those diabetes patients were consuming insulin and spending a fortune doing so. But the other resulting morbidities that are attached to diabetes, for example, heart disease, we have more heart disease and therefore more mortality than other countries. And we spend more than other countries. We're still at 17.5% of GDP. Although I'll come back to this chart later because there's some good news embedded in that chart. But included in your thoughts is a reference to the need to change our system to be focused on preventative care. I'm not sure that that's true yet. Until I see a health system that has demonstrated that it is capable of or needs to focus on preventative care, I'm not going to rush into that conclusion. I think healthcare currently is there to provide healthcare, and preventative care may be a completely different industry. Wellness, the gym industry, the food industry, the education industry. I haven't quite worked out how hospitals and preventative care go hand in hand. And I'm not sure that they should. Everyone has a mission in life, and they should execute on their mission well. So it's just an example of, I don't know what the right term is. I don't know if it's a trope, but I do know that there are many tropes out there when it comes to US healthcare. So we want to get into that. The general criticism or critique of US healthcare is we spend more than others and we get worse outcomes. That's how every article seems to start. That's the premise, the underlying implication. If it's not explicit, then it's implicit. That's how every book seems to be written on US healthcare. The underlying implication, if it's not explicit, we spend more and we get worse outcomes. So we're going to get into that. But I think the way to unpack that is to take many steps back and ideally start right at the beginning. And our hope is with you and with the additional thought leaders that we're going to continue to engage in discussion with over months and years to come, we will have many perspectives, and we'll test this premise, this foundational premise that we spend more and get worse outcomes. So let me start right at the very beginning. Our healthcare industry is heavily incentivized by the pursuit of profit, not just outcome, not just social good, the desire to keep people healthy, take care of one's citizens plus residents, asylum seekers, not just social good, but economic incentive for profit. Do you think there's something fundamentally wrong about the pursuit of profit in any and all industries, in healthcare? How do you view that concept within healthcare here in the US?
Well, first of all, I would say that depending on which sector of healthcare you're looking at, as you know, most of the large health systems are quote unquote not for profit.
About 70%, that's right.
And many payers are not, they're so in other words, they're for-profit models and they're not for profit models in almost every segment, or at least those two major segments. And it's of course you can get into what the definition of nonprofit really is, but in theory, not-for-profit health systems are basically just trying to generate enough of an operating profit to be able to provide the care that's necessary. They generally lose money on Medicare and Medicaid, and they quote unquote make it up on commercial patients. And on the whole, I think they do a pretty damn good job under pretty difficult circumstances. Obviously, there are for-profit systems, most obviously HCA, which is actually, I think, done a pretty good job of doing both. They're making money and they're also, providing high quality care. So I don't think it's clear that being a for-profit entity necessarily delivers, better or worse care than being a nonprofit organization. Mm-hmm. I think it's, there are bad actors always, but taking the profit incentive out of the system, I don't think is necessarily a good idea, even if you could do it. It's the for-profit incentive in healthcare and other aspects of our economy has driven innovation. And it's one of the reasons why, for example, our pharmaceutical industry, as much as people complain about it, is consistently, developed the most innovative medicines in the world, generally speaking.
Well,
Uh,
let's frame the industry for a second in completely. So if it's a $5 trillion spend, which it more or less is now, used to be four, now it's five. Of the 5 trillion, if call it around 3 trillion is on delivery of care, half of that 3 trillion is hospitals, hospital care, to call it 1.5 trillion. And don't hold me to every 100 billion, but more or less. And of that 1.5 trillion, let's assume that 70%, let's assume it's like for like, 70% of the 1.5 trillion is non-profit, right? So that's call it 750 billion. So that's 750 billion out of 5 trillion that is non-profit. That still leaves you with 4+ trillion that is all medical devices, all pharmaceuticals, half of all the payer work out there. So we're taking out Medicare and VA, but we're leaving commercial. And half of healthcare delivery, plus a third of hospital delivery. So all practices, all outpatient ambulatory, especially, you might want to deduct a little bit for nonprofit ownership of, but that's a small portion. Most nonprofits are not engaged in aggressive MSO acquisitions. So I would say the majority of the provision of care, when you include ambulatory, not the hospital inpatient, but outpatient, is for profit, right? So the majority of hospital care is nonprofit. The majority of the total pie of delivery of care is for profit. Then devices, then pharmaceuticals, then payer. It's a for-profit industry. And most of Medicare, Medicaid is about sponsoring the delivery of care, but the number of for-profit entities that engage in providing care to Medicaid and Medicare patients is enormous. They are for-profit entities. So actually, when you look at the total pie, the non-profit portion of US healthcare is very small, 750 billion out of 5 trillion. So this is a for-profit industry. So in that context, is for-profit in US healthcare a fundamental issue with this industry?
well, again, we could discuss the numbers, but one of the things that's happened, just to pick the delivery segment for a second, is over the past decade, health systems have expanded dramatically into ambulatory care. So, more than 50% of physicians in the United States are employed by large health systems. Now, again, so some of those for-profit health systems, some of them are not for profit. So they've moved very heavily into the ambulatory care space because, well, there are a lot of business reasons, to do that, as well as clinical reasons to do it, related to continuity of care. But I mean, to your overall point, do I think that the for-profit motive is bad for healthcare? I mean, you can argue that there are parts of it that, if you're not an ethical business person, then you're going to get undesirable results. But inherently, I haven't seen that it is. I think it cuts both ways. I think the for-profit motive has driven innovation and competitiveness, which has improved many aspects of healthcare. But I do think, for example, that there are, going back to the conversation we were having earlier about moving from a sixth system to a healthcare system. Lack of access to primary care, we know, is a significant driver of cost, generally speaking, and in the United States in particular. And there's a tremendous shortage of primary care physicians and primary care outlets. And that drives, additional incremental costs down the line. I mean, every payer will tell you that. And I totally believe that, and I've observed that. Lack of access to primary care, people basically, skip over stuff, and they aren't diagnosed as being diabetic, even though they are, or have early signs of heart disease. And then, those turn into acute episodes, which are not only very unfortunate for the person involved, but incredibly expensive. And we've got to fix that. I understand that, and I'm not endorsing RFK at all. There are puts and takes there. But one of the things that he's suggesting is that the Medicare fee schedule be adjusted so that primary care physicians get paid more and specialists get paid less. This needs to happen. otherwise there aren't going to be any primary care physicians in the United States anymore. If you see how hard they have to work basically in order to make a admittedly pretty good wage, but nevertheless not a fantastic one. I mean, it's a very, very tough job with the population we have. So there's some things that can be fixed here. And I'm off topic in terms of whether the profit motive is good or bad. I think it's good, on balance, but there are aspects of it and there are situations obviously where it's not good. So I think we have to resist the temptation, to overgeneralize, about something, either our system is better or their system is better. You have to, as you pointed out in the beginning, we're going to have to really dig into this to really come up with good answers. There are no easy answers here. And if you look around the world, there are no systems really, that are handling this in some kind of perfect way.
Yep.
And there are many different flavors of single payer. There's not just one. And, I think you actually have to live in those systems in order to really evaluate them, which is of course a challenge. But I haven't heard of anybody who's saying that any system, is materially better than somebody else's system. It's, there are puts and takes, and we need to figure out how to keep making our system better. That's the ultimate challenge.
Yeah, every stat has to be examined, and this topic is a complicated one. There are many different pieces to healthcare. So at a minimum, I've described 4 or 5 of them. They're all enormous industries, and they all have a lot of changing parts, and they need to be diagnosed correctly. And then the sum of the parts needs to be diagnosed correctly.
Right.
And then that needs to be compared to other countries before you get remotely close to answering this question. So it is at a minimum complicated. I'll give you an example of another chart I'll share with you. This is corporate employment of physicians in America since 2019 and this is non-hospital, this is MSOs, from around 90,000 physicians to 120,000 physicians in January 2021, and that trend has only continued. And these are the tuck-ins. These are the private equity-backed healthcare groups that are acquiring practices across America. And I can tell you, being in this space, there's very little, if any, competition with hospitals for these doctors. This is the transition of independent practices into corporate-owned practices. And for the most part, hospitals don't exist here. And so actually that rate of employment of physicians has stayed at around 50% for a while in terms of hospitals, and will likely stay there or come down as hospital leakage takes place with specialty groups that are more interested in equity ownership. These are physicians that want equity ownership, that don't get it at hospitals, leaving hospitals or avoiding ever being employed by hospitals in order to join that trend. And so what you see in hospital acquisitions is quite narrowly focused on certain core areas like primary care, which they're acutely sensitive to because they want the downstream referrals, and certain specialties that are still very well positioned within hospitals. High acuity specialties like oncology and cardiology, where the majority of procedures are still being performed for good reason inside of hospitals. But this idea that it's a hospital takeover, I think, is false. And I think the numbers support that. So that's one tiny piece of a much larger puzzle. My view on profit in US healthcare is that the experiment continues, but so far, and it's funny to call a $5 trillion industry an experiment, but so far, what I've seen in US healthcare is areas for improvement, areas that are systemically awkward and cause hardship, like price transparency. What are we actually paying for? Like fee for service, are we incentivizing volume? Like PBMs, pharmacy benefit managers that use rebates for reasons that are still unclear, that might benefit them versus the industry. So we still see these really painful anomalies, like the average price paid for a US drug versus the same drug overseas which probably drives a lot of people crazy. But that's not to say that we don't see similar stats that are incredibly positive, if not more stats that are positive, like the number of US healthcare startups versus other industries. So there's lots to be excited about, and it's worthy of real analysis. I do agree with you, there are always bad actors, and one bad actor doesn't tell you anything other than maybe you have a crack in your system. But beyond that, to take an example of an upset doctor, an upset nurse, an upset patient, I know the recent example with the United CEO, Brian Thompson, is front page news everywhere, and an example of one individual using, I believe, the argument of being denied care as justification and condemnation of an entire industry and its structure. And maybe even beyond that, the whole concept of the capitalist system called into question again, them versus us. What are your thoughts on this recent United CEO assassination?
Well, I'll give you them in a second. One thing I want to note is that the largest employer of physicians in the United States, as you know, is a large payer. You know, UnitedHealthcare.
United, that's right.
So it's interesting. I mean, there's a whole subject that I want to get into with you now or in the future about, the difference between payers and providers is certainly blurring here, for good reason. But anyway, going back to your question, it's unconscionable to think that there's any justification for murdering the CEO of UnitedHealthcare, no matter what he or his company may or
just the phrase "murdering the CEO of UnitedHealthcare" is insane.
It's totally insane. And so, the challenge, of course, and this is always true, and I think you alluded to it, is that the media picks up on individual stories and then tries to make general points about them. And there are certainly instances in which this system of prior authorization has been extremely painful, to patients. And there's legislation federally and also state legislation, that is now going to require payers to be more responsive and more transparent about prior authorization. One of the challenges is that a lot of that legislation, some of it has passed, but hasn't been implemented yet, and some of it's still, in flight. But that's the kind of thing that needs to be fixed, and fixed aggressively. That doesn't justify anybody's, horrible, inexcusable behavior. But those things, need to be identified. You mentioned another one, price transparency, which has actually, prices are much more transparent than people think they are, but you still have to dig for the information. So it's not really a market yet, and it needs to be. But those pain points in the system need to be addressed. But the history is that they can be and will be, maybe not fast enough. And I think that's true of prior authorization. I mean, some of the federal legislation that was passed last year, or I think maybe earlier this year, it does not go into effect until early 26. So the question is, why does it take so long? And the answer is there's some sort of, data systems related, reasons why it can't be implemented sooner. Perhaps that's true. I haven't, dug deeply enough into it, but that stuff needs to be fixed. But the outcry, I think, is to the extent that there is one, related to this horrific act, is a symptom, I think, of people's frustration with the healthcare system. And that goes back to my point, which is that the challenge that we have with healthcare in this country, to the point of your very good graphs, is that we have a very large, very sick, and very diverse population. And in trying to provide cost-effective care, under those circumstances is extremely challenging. And it's only going to get more challenging as the population continues to age. And, people are frustrated. And I totally understand those frustrations. But at some point, we're going to have to address the underlying issues here.
Yeah.
Because I don't see how, the most perfect system in the universe. When I think I started in the healthcare business, I don't know what the annual cost of healthcare was, but it wasn't anything close to $5 trillion.
Yeah.
Just keeps getting higher and higher, and it's outpacing the rate of inflation pretty consistently. And Medicare is going to go bankrupt, within 10 years by everybody's estimate, and something's going to have to be done about that. And so we don't have a sustainable system here. It may be better or slightly worse than somebody else's system, but the fact of the matter is it's not really sustainable, in its current form. We got to keep making it better.
Yeah, I don't agree with it. I don't agree with those statements. So when you say everybody, I'm included in everybody, and I disagree.
Okay.
So I think there's a lot of tropes in that. I push back on all of them.
Which part, though?
I think 10 years is a lot of time.
A lot of time to
change, improve. I think every second of the day, US healthcare improves. Every second.
No, I agree. No, I wasn't saying
someone is going commercial on a cheaper way of doing something, a smarter way of doing something, a better way of analyzing something in US healthcare every second of the day. And this chart that I'm sharing with you now demonstrates exactly that. This is US healthcare spending as a percentage of GDP in 2009. And this is US healthcare spending as a percentage of GDP in 2022. It's the same number.
Yeah.
And so the cost curve was bent, and it was bent fully. And what's interesting is while this has remained flat, all other G7 countries' percentage of healthcare spend, of their healthcare spend, has gone up during the same time frame significantly. Germany is now at 12 to 13% when it used to be 10 years ago 10%. France, the same. This question of frustration is global. So there's a lot in what you're saying that I obviously agree with. But it doesn't mean I agree with necessarily that the presumptive conclusions. We're going broke, it's not sustainable. That's the presumptive conclusion. That brings me back to the primary sentence, which is US healthcare is broken and needs urgent fixing, rewriting, rebuilding. I don't agree with any of that. There are a lot of patients across the world that are frustrated with lack of access to care, long wait times, arguably much longer wait times, bad outcomes, disincentivized clinicians, physicians, a lack of physicians, a wave of baby booming retiring generations that don't have supply. What a lot of those countries don't have is participation in payment. They don't have co-payments, they don't have deductibles, they don't have insurance premiums. The truth is, most of them do have that, but they have it at a 10 to 15% threshold of the spend, right? 10 to 15% is private insurance. The rest is, when you say single payer, there are very, very few pure single payer countries out there. The UK is 15% private market, private insurance. France, 15%. Germany, 10%, 15%. Right, you go from one country to the next, you're going to find some component of patient spend, but nothing like the US, where it's 50%. 50% insurance. Now, that payment is predominantly captured within an employer framework, right? The employer pays 20, 30%. The rest comes out of wages. So it's deducted. And then on top of that, individual payments for co-payments, right? So it feels very different in terms of the burden of responsibility. It's felt far more by patients here in the US, the cost of care. But the fundamental issues with care, am I getting a doctor when I need one? Am I getting the care I need when I need it, which is the primary determinant of satisfaction, right? Less cost, predominantly, do I get the care? Because care is mostly urgent. That is a universal cause for concern and frustration. The question of, and so if everyone has this problem, it doesn't mean that our system is broken.
It just means that we're in the business of healthcare, and supply and demand is an acute construct because it's urgent demand, always urgent drugs when I need them, nurses when I need them. It's always urgent. It's one of the things that make you healthcare, I should stop saying US healthcare, but healthcare special. How much urgency do you have for shoes? How much urgency do you have for a new TV? How much urgency do you have to fly to a vacation somewhere, right? Far less. The question of affordability and sustainability, I think it's a trope. Medicare is going bankrupt, I think is poorly placed. Medicare has $200 billion of US treasuries in savings. Medicare lends the federal government money. Medicare is sponsored by our income as Medicare tax that we all pay on our income, whether we like it or not. Taxes have gone up towards healthcare spend. That's part of Obamacare, an increase in spending towards Medicaid. Medicare has money. What Medicare is expecting to do over the next 10 years is see US healthcare become more cost effective. Can we sustain US healthcare at 17.6% of GDP? That's an interesting question. Even the 17.6% is interesting because I'm not sure that we've really broken down what GDP is. China has $18 trillion of GDP. Is it a bad thing? Right? We have $5 trillion of US healthcare GDP. Is it prima facie, on its face, a bad thing? Well, you have to break it down. A certain portion of that is export income, drugs that we sell overseas. That's included in the 17.6%. Is that a bad thing? Should we stop exporting drugs to other countries and get paid for it tomorrow? Because our healthcare GDP will come down if we do that. So at a minimum, when we compare GDP spend to other countries, we should remove exports. That's a fair comparison. We don't do that. We export more drugs than any other country. We get no benefit for it. In fact, it's a handicap to us when we have a conversation about our spend. And remember, the gap between our spend and other countries' spend is narrowing every year. Doesn't mean they'll all get to 17%, but my view of where we're heading is I think we're heading down from 17.6% because I think there's a lot of savings to come. It doesn't mean that you aren't ultimately right and Medicare doesn't go bankrupt in 5 years. It might. You might be absolutely right. But it is to say that I'm not sure that we should stop debating this assumption. I like the debate. I like pushing back. And I think it's a starting point for understanding where actually to focus on how to improve US healthcare. So I want to go back to this question of the CEO assassination. I think the CEO assassination is three things. One, something I completely don't understand. Because what the hell do I know about murdering CEOs? Nothing. It's just beyond me. It's beyond my comprehension. Two, it's either the random act of a total maniac who should go to jail forever and never be heard from again. Sad story. Didn't used to be a maniac. Doesn't seem to have used to be a maniac. So at some point lost his way. Horrifically tragic for the victim here, which is the CEO and his family, and the company, and the country, because people who aren't criminals shouldn't be assassinated in the streets of New York, period. Whether they broke the law, didn't break the law, made good decisions as a business leader, bad decisions, I'll leave that for the authors and biographers to decide. But just fundamentally, I'm pretty clear on number two. And number three, which I think may be the most interesting of all, is examining, as an aside, the public reaction. What is going on here that thousands and thousands of young people, some politicians, some journalists, it's not just journalists because this is happening in social media channels without the need for media companies and headlines. What is happening in item number three that this random act of unfiltered violence against a citizen who's not engaged in any kind of violence at all, but is just walking out of a hotel room, it is assassinated and it's justified. What is going on there? And I think that is interesting as a reflection on our own society, a moment where we stand in front of the mirror and take a look at ourselves. And I think it's not so much this person's act, but it's the culmination of events that lead to thousands of people to applaud this act that requires us to look at those events. What led us here? And I think it starts with, in healthcare at least, really bad headlines. Headlines on books, headlines on articles, headlines from politicians that paint a picture of a really corrupt and broken and malfeasant industry called US healthcare. And I think that's very tragic if the actual truth of it is it's 17.5 million people employed. It's the largest employer in the US. I think probably the US government is second, if I had to guess. But it's easily the largest employer in the US. And that's a lot of good people doing a lot of good things for 350 million recipients of care. And so don't they deserve better than those headlines?
No, they absolutely do. No question about it. And, just to be clear, when I say it's unsustainable, I think, yes, we have 10 years to clean it up in the case of Medicare. And I didn't think we could. I'm just saying that, we need to keep trying to make it better and more cost effective because we do have an aging population and it is a very sick population. And, it is going to eat us alive if we don't keep making it better. And there are lots of ways that it can get better. But look, the last time that Medicare, was basically refunded was more than 50 years ago, when there was a bipartisan effort, to, put a financial foundation in place for it. And that bought us another 50 years. But everybody, if you look at the past election, everybody is pointing their finger to everybody else and saying, no, we're not going to change Medicare. And as if the problem was just going to go away by itself. It's not going to go away by itself.
Again, I'm not sure I agree with that. I love you, Web, but I'm not sure I agree with it. Medicare Advantage is a change in Medicare. DRG pricing equals change in Medicare. RVU equals change in Medicare. Value-based care equals change in Medicare.
I agree, but I'm saying that those things you can't sit on your hands and
is a change in Medicare. IPAs and ACOs is a change in Medicare. Everything we do in health care benefits, that's good, benefits Medicare, and a lot of that change comes from Medicare itself. Medicare gets funded every single year through tax revenues.
Medicare has failed its financial sufficiency test.
Right.
Years in a row.
I agree. It used to have a surplus, a happy surplus, didn't know what to do with that surplus. The government used to borrow money from Medicare to fund other unrelated non-healthcare initiatives for years. It doesn't have a surplus, it has a deficit now. And so you extend out that deficit long enough, it runs out of money. And I think that is a problem that needs fixing. So I totally accept that.
That's all I'm saying is that, look, the things that you pointed to, I think are all signs of progress.
To say that they've sat on their hands and done nothing, while the problem has just gathered pace and momentum for 50 years, I think is unfair to, frankly, good regulators. And I'll be the first to say we're overregulated. I'll be the first to say that we could do things much better. But it doesn't mean that they've sat on their hands. Again, there's been progress in US healthcare. There's a lot of good KPIs out there. There's a lot of things that we lead the world in within US healthcare. I can list them for you. There's a lot of them. It's our health systems that are opening systems in remote places in the world that are bringing healthcare to the Middle East. It's our pharmaceutical companies that are exporting drugs by the truckload based on more new discoveries. It's our industry that's creating more health tech than any other healthcare industry across the world by orders of magnitude. It's our industry that actually does more value-based care, outcome-based reimbursement than any other country. There is no value-based care in Europe. It's all fee-for-service, all fee-for-service. There's a long list of things. There's a long list of outcomes. Now, the counter argument to that usually starts with, why is our life expectancy ranked pretty poorly compared to others? And that, for me, is a cheat. It's a poorly, lazy, constructed argument. There's 350 million people here, give or take. We're not quite sure how many non-citizen residents we have, whatever the latest terminology is. There are not 350 million people in New Zealand. I think there's 10, right? It's half of New York. We're comparing our country's healthcare to half of New York when we compare it to New Zealand. It's a complicated story to unpack life expectancy. Are you comparing apples to apples when you're comparing a 40% obesity rate to a 20% obesity rate? When you segment life expectancy into its more appropriate apples to apples comparisons, our healthy populace lives as long as any other healthy populace in the world, including Japan. If you look at our counties across America, those that have the healthiest stats have 90-year life expectancy, 95-year life expectancies. I think our peak is even higher than that. When you compare income levels across different countries, using health as a comparison,
Roy, I'm with you.
Well.
I'm with you, but and that's not, if we want to talk about how our system compares to other systems, that's a different subject. I'm just saying that we have to keep working on our system to make it better, right? And I'm not suggesting that our system is broken. I mean, I would never use that word, and I have tremendous respect.
That puts you and me in the minority.
Well, maybe it does, but look, sometimes you have to make a point to get people to keep moving. I mean, I've been hearing about the road from volume to value for the last 30 years, and actually, we have made progress with it, and hopefully we've reached an inflection point recently, but it's taken a hell of a long time to get here. And we still, are trying to figure out the model, and I applaud that.
Sure,
So,
but while we've struggled with a complicated reimbursement model, we've revolutionized closed, controlled networks through managed care. That's a revolution that has taken place.
I'm not arguing with the point. I'm saying we need to put our foot on the accelerator here.
Sure.
Right. So it's not. I'm a defender of the system in general, and if you want to compare our system to, other single payer systems, and there are a lot of different flavors. The issue about the percent of GDP is more a function of what their budgets are. I mean, they can set, and they do set in other countries, exactly how much it's going to be a percentage of GDP, more or less, because they budget for healthcare, which is why there are access problems in the UK, because they basically are. It's an effect. They're rationing.
Yeah.
They're running.
They're at 9.5% to 10%
money, and
with
so
3-year waiting lists. That's right.
Right, and so that's what happens, and so that's why they run out of money. There's a waiting list, and that's why there's a private insurance market there, because there are people who can afford to have single payer and something else too. That's obviously not everybody. So, I'm not saying, and I never have said, that our system. In fact, I wrote an article about this in which I essentially said, our system may be imperfect, but it's not any less imperfect than anybody else's system. So let's not blame it on that.
Yeah, look, it's a complicated argument. If we spent all our time cleaning up the misunderstanding of US healthcare within our public, we have 10%, actually 8 to 9% uninsured today. Of the 8 to 9% uninsured, 3 to 4%, so a third, are, I'll use the old term, illegal immigrants that don't have health insurance. There's 20 million of them. Maybe there's 15 million of them. That leaves you with 6% that are uninsured. The 6% uninsured are the gap between Medicaid eligible and buying insurance. I'm buying it. I'm good. I'm changing jobs. Maybe I didn't take care of it, or I just can't afford it, right? In truth, even that 6% have a safety net. Every person in America has a safety net. But just to have the conversation about what we're dealing with in America, it's 8 to 9% uninsured, of which a third is 15 to 20 million illegal immigrants. Every conversation we have about US healthcare requires qualifiers because it's all complicated. We have so many different systems within US healthcare. We have a single payer. We have a single payer who's also a single provider. The VA, I think, is the largest single provider of care in the country with the largest budget. I think it's something like $600 billion. Don't hold me exactly to it. It is single payer, it is single provider. So we can examine it. What's the quality of care in the VA? How does it deal with no competition in the delivery of care across the country? There's plenty of these wonderful case studies. We don't get into the weeds. But back to this larger theme of how to influence the public. I don't know if we cleaned up these headlines and started every article with US healthcare not broken. US healthcare, best in the world, still needs to improve. US healthcare, best in the world, still needs to improve urgently, because all healthcare across the world is urgent and under pressure. Healthcare in Japan is under pressure. They're running out of people. Their population is shrinking. Healthcare in China, which, by the way, when you think about comparing US healthcare to other countries, it should really only be Japan, China, India, large countries with huge populations dealing with aging, right? China's healthcare is a disaster in many ways, probably the worst in the world for its size and its GDP.
Yeah, no, not arguing about that at all.
Japanese healthcare is struggling to find people, but guess what? Japanese life expectancy as a mass, as a country, is best in the world. Why? Homogeneous society, a lot more than ours. We think we're homogeneous because there's a lot of people speaking English. We're about as heterogeneous as it gets. We're a mix, a salad bowl of everything. They have the same diet, they have the same lifestyle, they have the same religion, they have the same obesity rates, they have the same approach to everything. By the way, they tend to smoke and drink a fair amount, but you get a very nice life expectancy when all those stats are much better than ours as a population. So even though they have a relatively weak health system, underfunded, undersupplied, they just don't need it that much. So if we were to fix all those headlines and get them right, would social media still celebrate the assassination of a CEO, the murder of a high-profile CEO just because he's a CEO, just because he's a he, just because it's a capitalist system, just because he's made money? I'm sure he was very well paid. Maybe. I don't know. I mean,
No, it would, but it's not going to
sold
happen.
jeans for a living and he
Yeah,
was
but-
assassinated on the streets. Would anyone care? I don't know.
Well,
But I
look,
think
I
it's
think
it's worth cleaning up those headlines nevertheless, because it feels like the right thing to do.
well, it's certainly worth trying. But you know what you put your finger on here is that, you know, everything that happens in the universe is, you know, is going to of consequence is going to be a headline, and it's going to be blown out of proportion, you know, and that's
The public needs its entertainment.
that's a fundamental issue that I think we're never going to, you know, not likely to solve. And I think, you know, to some degree, I think people, you know, have learned, hopefully to some degree to ignore the headlines and to just focus. And what we need to do is ignore the headlines and focus on the underlying issues.
Yeah.
And have solutions and stop pointing fingers at each other.
Oh,
and that's,
amen.
That's the problem that we have in the United States, is that we're not focused on solutions.
You and I are doing that. We're starting this revolution today on behalf of the country. Now, I know there have been many revolutions in this country for centuries. And actually, there's a really cool one underway in the food industry. And there's a really cool, exciting revolution underway in the health industry, which is not the same as the healthcare industry. And that nuanced difference makes all the difference in the world. If we could help listeners, who in turn help other listeners, understand that the health industry in America has almost nothing to do with the healthcare industry, except that it's the source of supply. It comes ahead of the healthcare. Healthcare reacts to our health. Our health speaks to our obesity stats, our physical activity stats, right? Our lifestyle. And whether it's intentional, whether it's something we can control, or whether we need assistance, medication. I know GLP-1 now is all the rage in controlling desire for food, and now apparently desire for alcohol, the miracle drug. These things speak to our health, right? So moving topic, the health of America. Does the public understand the extent to which we started a handicap, and the extent to which there's a Pareto effect going on in our industry, where 80% of the spend, the whole spend, drugs, devices, facilities, clinicians, is directed at 20% of the population that is chronically unwell?
Well, there was interesting. One of the things that got me into the retail medicine business and really kind of gave me the idea for Ready Clinic is there was a study by an organization called the New England Complex Systems Institute. This was literally 20 plus years ago, in which they analyzed the US healthcare system, and their general conclusion was that it's really, really good at handling a relatively small number of highly complex conditions, but not so good at handling a large number of routine conditions. And they were sort of getting at the fact that, you know, if you have some really serious problem, you're going to come to the United States because we're way ahead of the pack in terms of being able to handle those things. On the other hand, at a population health level, you know, just basic nutrition, basic vaccinations, if you don't want to get into that debate, basic preventive care, we're not where we need to be. I'm not saying we're any worse than any other system, but again, at some point you have to address the underlying issues here, and we need to improve the health of our population. And there is something called population health, and it is being recognized now as a thing, and it's being bonused in some ways, within some value-based contracts. But that's where we have to get at these fundamental drivers that result in having to handle these very complex conditions and very expensive ones. And that's the system we have is really designed to be responsive and not proactive. And the question I have for you is, how do you think we can flip that coin and make our system more proactive?
Yeah, I don't think there's been a healthcare industry in the world that has solved that.
No, there hasn't.
It is a fundamental. It is. What's the term I like to use? But it's a riddle. There's a better term for it. And why? Because it has fundamental conflicting needs. They're in perfect conflict with each other. And you hear it in people's criticisms. On the one hand, and these are the same politicians, these are the same healthcare leaders. On the one hand, how dare we deny care? How dare we? I want to see a primary care physician. I should see one today. I want care that follows whatever meeting or consultation I had because I have a condition. I need it immediately. That is my God-given right. On the other hand, how dare we spend so much on healthcare? How dare those doctors earn the incomes that they do here in the US when they earn a third of that? They're not even called doctors in Europe. They're called consultants. They don't even get the privilege of being called doctors. How dare we spend so much on new drug development? How dare we, right? And those two things are in direct conflict. I want limitless supply. I want a constrained supply. And so is there a solution for that? I think there is. And I think we found it. We just don't know that we found it. And that's why I think this first podcast is really important, because we're going to tell the world that we found it. We've discovered the elixir to this problem. And the elixir is experimentation, innovation, the incentive to pick away. And so my critique US healthcare, the criticism of US healthcare, is that the pros are poor. They're too dramatic. It's for theatrical effect. And it whips us into a fury where every politician can't wait to destroy US healthcare in its totality. Rip it apart, they say. I'm quoting, I'm not even paraphrasing. Rip it apart, right? And what we don't appreciate is the nuance that we haven't solved for the problem, the inherent problem of the need for limitless supply versus the constraint of supply. But we have solved for it because given time, stochastically, every second of every day, we are working on supply. And you see it, I see it. I'm going to ask you in your experience as a CEO, how hard was it to grow your businesses? How hard was it to refine them? Because no CEO grows in the right direction without calibrating all the time, right? How hard was that calibration? How hard was it to find talented people? My assumption is most of your given business was full of talented people. How hard was it to keep the majority incentivized, working hard? We are 3 times more productive than our European counterparts. 3 times more, not 10% more, 3 times more on a GDP per capita basis. Some of our states are 4 times more productive, depending on which state you pick at, right? Indiana is different than New York. New York is different than Florida, right? But consistently as a country, we're approaching 30 trillion. We'll hit 30 trillion of GDP next year, 10 times more, 10 times the UK, France, maybe 7 times more Germany, don't hold me to that. Our population is not 10 times larger than the UK population, right? We don't have 600-700 million people here in the US, right? So more people are working. By the way, attaching health insurance to your job keeps people quite focused on their job. Attaching health insurance to being a citizen creates a break between a real gap between your job and the benefits of working. Europe has a really strong social safety net. They're very proud of it. No one works. They're less than stagnation. They're in depression. They're in a multi-year-long depression where the rest of the world just gets larger. Asia continues to grow at a rapid pace. Africa grows at the fastest pace of all. America grows at a very healthy pace. Europe doesn't. So I don't know that we want to race to emulate Norway and Sweden.
No, we don't. I mean, I don't, and I certainly don't, don't think that I do, because I've said that in print, let's not.
But we haven't solved the problem.
Right, but that's the thing.
That's the best I can offer you is we're definitely working on it. And I'm interested in your experience as a CEO in general, that this industry that you lived in, that you still live in, that we both live in, our home, that this country that we live in, did it enable you to be able to create value and solutions?
Oh, yeah, look, and no question, and then it's I think what people say about the U.S. economy. It may not be perfect, but it's still the best one in the world.
I would agree with that.
Right. So, I mean, I'm with you. I'm a capitalist at heart, and I've lived that life. Now, having said that, I also have faced some of the intransigence of the U.S. healthcare system, and it took me 10 years, of really hard work to try to, even create an environment where a retail-based clinic could be successful. Just overcoming the external obstacles to success. I think the healthcare system in the last decade has reached an inflection point where, the persistent cost increases from the payers, not just the commercial payers, but employers, have been, so difficult to manage that now the system is much more receptive to innovation than it was, 20 years ago or 30 years ago. So I think it's changed dramatically, and I'm totally in favor of that. I'm just saying, we need to keep our foot on the accelerator here because it's still not working the way it needs to. And, I'm not saying it's, I'm definitely saying we should not adopt single payer. I don't believe in that. I don't think it's been successful. And I think the transition to single payer in this country, if we tried to do it, would be immensely expensive and it would be disastrous. So we need to fix what we have, improve what we have. I love what we have. I've spent my life in it, and I have tremendous respect for most of the people that I've met. You are hardworking and well-intentioned, and that's one of the great things about healthcare is, you meet people, and people who are in healthcare usually are in healthcare because they want to help people, but they realize that, no money, no mission, right? So you can't have an organization that's not making money and still pursue your mission. And so, there's that too. You have to have both of those things, and sometimes they're hard to achieve, but it's possible. And I think we are in a place now in healthcare where there is more innovation, and it needs to be encouraged, because you're absolutely right that the only way out of this fix, and it's not just our fix, it's everybody's fix, is more innovation and more productivity. And whatever we can do to stimulate that needs to be done.
So the two bugaboos, the two primary sources of market frustration in the US over the last 50 years that rise above, head and shoulders above all other industries, in my opinion, are education and healthcare. Most of college education, I think, in America is private. There is state-sponsored education, but my sense of it, I haven't done as much research. So the vast majority of people are going to college and engaging in student loan. There's $1.5 trillion of student loan outstanding. Again, don't hold me to the $100 billion range, but it grows, and it sits on top of families and is a source of unhappiness. It's not a source of happiness. Attached to that, US healthcare, and you see frequent reference to personal healthcare bankruptcy. I'm out. I can't afford my house. I had a procedure. It's cost me everything. US healthcare grew along with US education at a rate of 10% per year, more or less, for about 50 years. The US economy did not grow at that rate. It's really unbelievable when you look back to 1950 to today. Decade after decade after decade at that cumulative rate, both industries. Our income has grown at a rate of 3% per year. So we've all been getting much wealthier in terms of everything else. For $1,000 on a flat screen TV, you get a much better experience than you got in 1950, right? Much wealthier in terms of digital technology, smartphones, much wealthier in terms of maybe even our food. There's a lot being criticized, but access to food, variety in food, lots of things have gotten noticeably better, and you still spend, I don't know, $4 on a yogurt, $5 on a yogurt. It's not $400 for a yogurt. And here are these two industries, $100,000 per year to get a college education, an enormous amount of money to pick a procedure. The difference between US healthcare and US education is healthcare for the last 10 years, 15 years, has grown at a rate of 3% per year. And that's a revolution, an enormous one. No one's spoken about it, but it happened. That's why we're still at 17.6%, because we've grown at the same rate as the entire US economy. Education hasn't slowed down 1 inch, still 10% a year. Nothing's changed. And I think, by the way, not enough time and effort is spent on unpacking education. Truly, this is not about writing off student debt. This is about, why does it keep coming? And we don't have that conversation. But what's interesting about US healthcare is that there are still pockets within it that are trying to break what's fixed. And if you look at those pockets, drugs, we spend more than just on insulin. I know insulin is now fixed. There's no more money in insulin. It took 50 years, but they fixed it finally. It's drugs, it's hospitals, it's payers. Drugs, PBMs, 80% market share, four organizing companies, each of them doing $200, $300 billion of revenue as PBMs. It's an oligopoly by definition, incentivized to increase drug prices, not to protect us. And the proof is in the outcomes. We spend on average 3 to 4 times more per drug than any other country. And in some cases, 10 times more for the same drug. Same drug. I don't know that we spend 10 times more to fly in a plane than any other country, 10 times more to buy a car. How would we feel if we spent 10 times more to buy a car than any other country? What would we do as a society? How far would we accept that? And yet the argument healthcare is too complicated keeps us from demanding change now. Hospitals, they're still growing at 10% a year, their costs. And yet we have a payer system. I'm not talking about PBMs, but we have a payer system other than those that own hospitals like United. But we have other payers that are not incentivized to allow those hospitals to grow those costs at 10% per year. That's a lot of usage, right? And they keep the spread between utilization and premiums. And so this works against them, and yet they allow it. I have to believe that that's monopolistic power. That's health systems in certain markets that control access to care and get to do whatever they want. They package into that 10% increase a reference to wage increases and unions and lots of fixed assets and infrastructure. But at the end of the day, their costs, their income is growing at 3.5%, 3.5 times, the rate of growth of everyone else's income in the country. Me first, you second. I used to have this conversation with my physician in-laws who used to do very well without a network. And I used to say to them, why you? Why you versus the rest of the country? We're all in this together, right? And it doesn't feel right when one group consistently, year in, recession out, depression in, depression out. There's a great mandate that hospitals have to take care of the truly sick, that have no means, right? And they take care of those people, and that's fantastic. And they should be applauded and they should be protected. But I don't know that that translates to 10% a year every year.
Yeah, well, I mean,
So
look,
the drugs, the hospitals, and the payers, where I don't know if public focuses on this, but pick a state, any state in America, you'll find one payer, commercial, controls at least 50% of the market.
yeah, well, that's what I was about to say. There's been consolidation on both sides, right?
Right.
And so health systems have gotten bigger, payers
One monopoly versus another.
Yeah, exactly. They're trying to gain leverage over each other for obvious reasons. But it's in the end, it's been a zero-sum game. I mean, the reality is, and people, want to blame it on health systems or they want to blame it on payers. I mean, there's been consolidation. There are some good reasons for consolidation.
Yeah.
The administrative burden, and I haven't been on the provider side, the administrative burden of, getting paid when you have, hundreds, if not thousands of different contracts, is huge and very wasteful. So anywhere from 7.5% to 15% of total healthcare costs are administratively oriented. I'm sure you have something on that.
I'm showing you a chart here, which I think is fascinating. Our population, 1970, 200 million. 2020, 340 million, larger now, right? Almost doubled during this period of time, 50 years. Number of hospitals, 1970, 8,000 across America. 2020, 4,900. So we have 3,000 less hospitals, almost half the amount, taking care of almost 2 times the population. Now, thank God for our outpatient world that has picked up a lot of healthcare patients. This reality has not existed in a place like France, where the outpatient world is tiny and everything is pretty much still flowing through hospitals. Their coordination of care, which by the way is a category that doesn't really exist in Europe. We have coordinated care. We have coordination of care businesses. That's all they do in America. They don't actually provide care, they just coordinate care. They don't have coordination of care truly that functions at a high level in these other countries. Patients just get stuck and nothing happens. That's part of the waiting list, is just the inability for the right hand to coordinate with the left hand, this specialist to deal with that primary care provider or that specialist, and participate in, by the way, block and tackle group care. There's a lot of coordinated care that involves multiple specialties working together in the US. But here we have hospitals that are just consolidating, disappearing, taking care of twice the population. This feels hospital inflationary to me. I'm not sure how so much fewer hospitals taking care of so many more people results in hospital controlled pricing.
Well,
it's like a lot of leverage for those that remain.
If you showed that graph for payer consolidation too,
it would be the same thing.
You'd see a very similar trend. And like there's, I mean, it's like everything else, it's complicated, but there has been in the United States, particularly over the last decade, to your point, a tremendous move towards more outpatient and ambulatory care. And that's being driven by technology to some degree. So you have ambulatory surgery centers, which are less expensive than hospitals.
Yeah.
Actually,
Where none existed, we now have 6,000.
right. And so, you've got a lot, I mean, there's urgent care, there's virtual care, there are rehabilitation clinics, there are skilled nursing facilities, there are all sorts of outpatient settings that didn't really exist to any significant degree. And hospitals or hospital owners are actually trying to drive that. They're trying to drive that care out of the hospital because it actually is more cost effective and patients like it better. So, this is an example of where there has been innovation in the system and it's pretty much good for everybody. And that's going to continue.
But it hasn't translated to a slowdown in annual hospital price increases. That is the final test.
Well, but
bring the whole system down to 3%.
Then we're changing sides here because I think I would say that if there may have been increases in hospital costs, and we can go back and talk about labor costs driving that because labor costs.
By the way, the Price Transparency Act introduced by the Trump regime in his first term has done nothing to slow that down.
Well, that's partially because, as I mentioned before, people don't know how to get the information, and it's slowly but surely kind of seeping, into the system.
That was my next question. Some of these regulations might already be there and doing work. Will they show up over time? The Inflation Reduction Act, which, to my knowledge, one of the best things about it is that it capped drug price increases and forced a rebate for any increase that exceeds national inflation. What a surprise. They're attaching increases to national inflation. Any increase that exceeds that goes back to Medicare as a form of rebate. Will that translate to a much slower increase in annual drug prices? I don't know.
Right.
I haven't seen the data yet.
True, but let's, we'll have to unpack that one too. So if you want to look at it this way, one of the benefits of a single payer system is they get to use the government's entire leverage to negotiate drug prices. So when the government of New Zealand, negotiates with Novo Nordisk, they get a better deal, right?
Although I don't think with their spend for a 10 million populace, they're getting such.
They still get a better deal.
Yeah.
They do, right?
Yeah.
That's been, part of the argument here is why the heck, isn't Medicare allowed to use its leverage to get better drug prices?
But this is what's strange. So CVS Health, Caremark, United Health Group, OptumRx, Cigna, Express Scripts, and one more, I can't remember, control 80% of the market. Each one of them, CVS Health Caremark is 350 billion in revs. United Healthcare, OptumRx, 370 billion. Express Scripts, Cigna, 180 billion. These are big entities. Their PBM CEOs, Andrew Whitty, Karen Lynch, I looked at ChatGPT, 20 million in annual income each. These are powerful organizations that control pretty much the market. You're telling me they can't negotiate a drug price?
Well, but they're not nearly as big as Medicare, right? So the issue has been, should Medicare be allowed to negotiate with pharmaceutical manufacturers directly, which until the inflation
Medicare, I mean, let's not exaggerate Medicare. 600 billion? It's not
Medicare.
billion.
Yeah, Medicare is
800 billion?
Medicare is big. It's 60% of the market.
It's not 60% of the market because total government spend is 50%. And that's Medicaid and VA. So it's not 60%. But we could do it now, right? Let's see that I get into ChatGPT. I'm going to skip Google. Medicare annual spend in the US.
I'm saying government payers, we can call
848 billion, 2023. Right. So it's not 8 trillion. And these PBMs control 80% of the drug spend. These 4 of them. And you're telling me
the commercial
they can't show up and say, this is ridiculous.
Oh, look,
you guys are overcharging us to the tune of 3-4 times what any other country, what Canada up north, what Mexico down south is paying for the exact same. They can't have that. They're not large enough to have that conversation. Something is fishy in those waters. Can you agree?
Well, yeah, you're right. There's vertical integration there, obviously. So
there's some misaligned incentives. If they
well,
get
this is another,
more for
this is
more
another subject for conversation because historically the FTC has been all about preventing horizontal consolidation, right? We don't want Rite Aid to merge with Walgreens because then they have too many pharmacy outlets. But what CVS has done, as an example, they vertically integrated, and that's been allowed, under basically the laws that impact.
We didn't understand incentives because they're hard to understand.
And now
you see
now
the
they
results.
want to take it apart.
The proof is unavoidable. It's staring us in the face.
Right. But there is this. So, and PBMs are a complex animal unto themselves. Most people don't even know what a PBM does or how they do it. And I devoted an article to that too. But this whole question of, because single payers are able to negotiate for their entire population, with a drug company, that's one of the reasons that they get lower prices, right? Medicare has not been allowed until the Inflation Reduction Act to negotiate directly with pharmaceutical companies, but it's been
crazy. It is crazy that it took that long.
But still, it's very limited, right? It's very limited.
That's 2 years ago. It's 2 years ago that this happened.
Right. There are only 10 drugs that they've been allowed to negotiate on.
Yes.
Now, and it's going to expand it. Okay, well, fine. Okay, so I'm with you there in terms of being able to negotiate lower drug prices, but you are going to have to go back to what we were discussing before, which is, all right, at what point, if the government can use the full force of its, however many people on Medicare to negotiate a lower price, do you start impacting pharmaceutical pharmaceutical revenue?
You know what's going to happen?
Yeah. Okay. So
I hate to say it, but this is NATO. We're going to spend less, and other countries will spend more.
Right.
That's what will happen.
And so, okay, you think that's going to happen?
Yep. Because the drug prices are not giving up a point of margin, not one. They're just going to go somewhere else and negotiate harder.
Well,
How do you
negotiate harder when you
there's money? There's money. There's money in China. There's money in Japan. There's money in Germany. There are markets that are full of wealth, full of income, full of productivity, want their populations to be healthy. And just like defense, which we're getting off topic, but I know that we've gotten a lot of benefit from defense in terms of statecraft and diplomacy. But boy, on paper, are we spending 90 cents of every dollar worldwide? It's all coming through us.
Look, if you're
pharmaceuticals, defense, it feels very analogous.
Yeah, but we're being realistic. You're Merck, and you have one product in a category that has 3 or 4 drugs, and you only have one buyer in Germany, right? So it's not like you can say, well, if you don't like my price, then you don't get my drug because they're just going to use somebody else's drug. Now, if you're in an orphan drug category or something, that's different. But the point is, when you're negotiating with a payer,
largest company in Europe is a drug company, Novo Nordisk. They've been making insane profits for 100 years. Started with insulin. I just listened to this amazing podcast on Acquire.
Right, but you got the point,
insulin,
right?
And now GLP-1.
Okay, but are you saying you want Medicare to be able to negotiate directly with pharmaceutical companies without any boundaries? So yes.
Yeah.
So, and you don't think that?
I think the drug companies are big and smart and interesting and will find a way to make a compelling offer to the German market that works for everyone. Nobody wins if the best drug is not interested in supplying German populace. Nobody wins. And so there's a natural negotiation that's taking place. Right now, it's unnatural because no one's negotiating on behalf of US patients. Nobody. It's one-sided. We spend 4 times more on average than everyone else. That is unsustainable.
Well, I agree with you, and I wrote an article about that too. I'm just saying that in the effort.
Hospital price increases 10% per year, unsustainable. College tuition, unsustainable. These things are unsustainable. They
Now you're using the
within
language
healthcare.
you're using the language that I used at the beginning.
Yes, but they're pieces.
Right. Well, yeah.
They're
Pieces.
not on their own US healthcare.
That's what I said, right? I said
We have a house and the toilet doesn't work. Should we move out? Let's go fix the toilet.
No, I agree. I said we're in violent agreement. But
on that note, Webb, are there any other thoughts that you want to cover? I think it was a really robust first podcast at a macro level. Is US healthcare broken? We think not.
This is fun. Look, there's a million other things that I look forward to covering. This is a good way to start. And it's a huge challenge to continue to make the health system that we have better, but we can do it. But we have to have adult conversations about it. It can't be ideological, and it can't be headlines. And it's not about whether the health system is broken or it's perfect.
This is what kills me.
Here's something
everyone starts this conversation with already knowing, because they heard someone say something elsewhere, and that person's must be credible because they come out of Stanford or they come out of Johns Hopkins. No one actually reads the studies. I read the studies. No one reads the books on healthcare. I went to Barnes and Nobles to buy and read more books. I'm a fast reader on healthcare. The stand on healthcare business books, by the way, you're in it, is about as far away and hidden as you can possibly imagine within a very large Barnes and Nobles.
No, totally.
Somewhere next to the toilet, you'll find a category called healthcare management books. And it's a very small section. No one has done the reading. The authors have written, and what we've taken from their work is the one or two headlines. US healthcare is broken, right? Worst in the world. Another study just came out. What was the group? Commonwealth. Is it Commonwealth?
Yeah,
came out recently. Last again. Read the study, and in case they listen to this, I'm not going to attach any adjectives to it. But I read the study. I read what it means to do a survey about equity in healthcare, and based on the limited results of US patients, but we couldn't really interview anyone in the other countries because we don't have that kind of access, we're going to rank ourselves last. And there's only 7 categories. In the category of cost, because US healthcare actually costs money, we automatically rank last. This is the quality of what supports these headlines. Where in their study, wait times? Nowhere. Comparative wait times? Nowhere. And yet they offer access as a comparison. Where in their study, number of healthcare IT startups that have achieved significant value and made a meaningful difference. The application of digital solutions within healthcare by comparison across countries. Where is it? Value-based care across countries. Where is it? True health stats, outcomes on like-for-like comparisons. Compare obesity groups across countries. Life expectancy, outcomes, compare that. Where's that comparison? Obesity groups by country. No, we compare entire populations. All of US to New Zealand, half of New York. It's madness. We have to stop. We can do better. Thank you, Webb.
We can dig deeper, which is what we're going to do.
All right. Thank you, my friend.
All right. Take care.